Good afternoon, everyone. My name is June Kim, Program Director of Technical Assistance, and on behalf of AAPCHO, I'd like to welcome you to the first in a 5-part series of AAPCHO's Practice Transformation webinars. AAPCHO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of medically underserved Asian Americans, Native Hawaiians, and other Pacific Islanders. With the rapid changes that are occurring within the healthcare landscape, we hope that we can better serve Asian American, Native Hawaiian, and other Pacific Islanders serving community health centers with the latest information on practice transformation.
The goal of our series is to provide you with the latest on quality improvement, meaningful use, accountable care organizations, and patient-centered medical homes, and to explain how they affect all of you and your clinics. In the last webinar of this series, we'll also be providing you with an analysis on the cultural and language access standards that we are seeing across each of these practice transformation efforts. Today's webinar is entitled Quality Improvement, Implications for Community Health Centers Serving AA&NHOPIs, and our speaker is Ignatius Bao. Ignatius is a leader in health policy analysis, particularly around patient-centered care and healthcare reform. Prior to establishing his own consulting practice, Ignatius was a program officer and program director at the California Endowment, director of health policy and programs at the Asian and Pacific Islander Health Forum, and civil rights and immigration law attorney at the Lawyers Committee for Civil Rights in the San Francisco Bay Area. He was also part of the community effort that resulted in the creation of the first White House Initiative on Asian Americans and Pacific Islanders, and was a principal author in the first report from the President's Advisory Commission on Asian Americans and Pacific Islanders. Ignatius is a champion for the Asian American, Native Hawaiian, and Pacific Islander community, and a great AAPCHO supporter and ally. We are honored to have him with us today and for this 5-part series. Before we get started, I wanted to review a few housekeeping items with you and let you know how you can participate in today's webinar. Here on the screen, what you're seeing is an example of the GoToWebinar attendee interface, which is made up of 2 parts. The viewer window shown here on the right, but maybe on the left depending on your browser or computer operating system, allows you to see everything the presenter will be sharing with you on your screen. The control panel also allows you to participate in the webinar. By clicking on the orange arrow button, you can either hide or show your control panel. You can also set the control panel to auto-hide or not to go to auto-hide by going to the View menu. Please note that all attendees are in listen-only mode and will be muted during Ignatius's presentation. You may submit questions in writing during the presentation by typing them into the questions field on your control panel. We will be reviewing the questions as they come in and will address them during our Q&A session after the presentation. Lastly, please note that today's webinar is being recorded and that you will receive an email with a link to view a recording of today's presentation after the webinar. With that, I'll pass the webinar over to Ignatius.
Great, thank you so much, June, and thank you everyone for joining us. I understand we've got over 60 people on the webinar, and I'm really looking forward to sharing this information with you. As June mentioned, this is the first of 5 webinars, which are meant to be cumulative, and so today we're going to do an overview and introduction to the issue of quality improvement and practice transformation and how that applies to community health centers that are particularly serving medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders. So in today's webinar, what we're going to do is provide that overview and talk about some of the key frameworks for quality improvement, as well as how the Affordable Care Act passed in 2010 supports these efforts as a central part of healthcare reform, and then finally focus in on what the key implications are for community health centers who are serving medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders. So to start with, we asked this question, what do we know about the quality of healthcare in the United States? And unfortunately, the answer is actually not very good. that there are widespread medical errors, especially in hospitals. There's generally a failure to follow acceptable and accepted clinical guidelines in what we call evidence-based medicine, that there are wide variations by region and geography in utilization and costs that are unrelated to the actual outcomes in healthcare, and that there is widespread waste and overutilization from both fragmentation in the healthcare system and defensive medicine. So I'm going to talk a little bit about each of these 4 points. First, in 1999, and so this is over 15 years ago, the Institute of Medicine released the first of a series of really groundbreaking reports about healthcare quality in the United States. And what this report reported way back in 1999 is that there was widespread overuse, underuse, and misuse in medicine and in healthcare that resulted in anywhere from 44,000 to 98,000 preventable deaths every year. What this meant was that our healthcare system was not just not helping people, but it was actually causing harm. And this was a very sobering wake-up call, particularly for hospitals, to do better, to say that this level of error and this level of harm was actually not acceptable in our healthcare system. More recently, the Institute of Medicine has focused on this question and come up with 2 additional data points which are going to be important both in this presentation and then in the webinar series as we talk about how we can do better from this perspective of healthcare quality. So the first data point is that up to 1/3 of hospital patients, another way of thinking about that 44,000 to 98,000 individuals, that up to 1/3 of individuals, again, are harmed during their stay in a hospital. And again, that's not acceptable. And then secondly, that for Medicare patients, about 1 out of 5 Medicare patients are re-hospitalized for a preventable or avoidable reason after they're discharged from the hospital. And so there are questions that are raised by that data point about the kind of continuity of care and the coordination of care across different settings, in this case, when a patient is discharged from the hospital. This report came out in 2012, so a couple of years ago, and again, even though the original report came out in 1999, things hadn't gotten very much better in those nearly 15 years. And not to pick on or focus only on the hospital or inpatient setting, a couple of years later, in 2003, there was this groundbreaking study published in the New England Journal of Medicine from researchers at the RAND Corporation, which talked about the quality of health care in outpatient or ambulatory settings. And this next slide is very, very busy, but it essentially shows that when there was consensus among clinicians about appropriate care and treatment for particular conditions like breast cancer or depression or diabetes, whether or not clinicians were actually following these clinical guidelines. We're doing relatively well for a disease and condition like breast cancer. Nearly 3/4 of clinicians were following the recommended treatment guidelines. But if you go all the way down the list for something like alcohol dependency, only 1 in 10 were actually following that recommended treatment guideline. And for something like diabetes, it was less than 50%. It was only 45%. So overall, the quality of care, even in the outpatient setting, again, where there is clear clinical consensus and guidance on what should be happening when someone has that diagnosis or condition, it was only about 50% of the time and less for many, many conditions. This study was published in 2003, and every year the Agency for Healthcare Quality and Research essentially updates that report with something called the National Healthcare Quality Report, as well as the National Healthcare Disparities Report. And in that time period, we know that there actually have been improvements, which is the good news, that especially for acute care services, folks now are receiving the recommended guidance or treatment about 80% of the time, We're doing better in terms of chronic disease management. The numbers have moved from about 40 to 50% to about 70%, but we're still lagging behind in terms of preventive healthcare services, which are only being followed about 60% of the time. I'm now going to run through some specific data from these national healthcare quality reports and disparities reports from the Agency for Healthcare Quality and Research, and really focus in on the disparities in the quality of care received by racial and ethnic minorities, low-income individuals, and limited English proficient individuals, particularly Asian Americans, Native Hawaiians, and Pacific Islanders. So for this first data where we expect someone simply to have a regular or usual primary care provider, if you look at the right slide for folks who are 65 and above, that number is 90%, and that makes sense because almost all those folks are receiving Medicare, so they have health insurance and they have someone that they can call their primary care provider. If you look on the left-hand side, the last chart shows that for Asian Americans, less than 70%, and it bounces around a little bit over time, but the latest numbers are from 2011, that less than 70% of Asian Americans could say that they had a usual primary care provider. So that's a 20-point gap between the highest for people 65 and over and for Asian Americans. Then for something as basic as whether or not they're receiving this preventive service of having a pneumonia vaccine or immunization, again, we are setting a benchmark for being about 67% of the population. But if you look at the left-hand side, the blue dot for Asian Americans hovers around 40%. So again, a huge differential between what our benchmark should be and what Asian Americans are actually receiving in terms of the quality of care. For Native Hawaiians and Pacific Islanders, this data comes from the Centers for Disease Control and Prevention, that for folks that are insured, there's still a differential between whites and Native Hawaiians and Pacific Islanders in terms of who receives a cholesterol check within the last 5 years. And it's even worse for those who don't have health insurance. For Native Hawaiians and Pacific Islanders, it's less than 40% receiving this cholesterol check. And then for something as widespread as diabetes, in which we have now a lot of clear clinical guidance and lots of quality measures about how to help people manage their diabetes. This data is from the California Health Interview Survey, which disaggregates the data by different Asian subgroups. We find that for California as a whole, we're doing relatively well, that for people with diabetes, they have a management plan for their diabetes nearly 80% of the time, but those numbers are much lower for some of the Asian subgroups, particularly for South Asians, that the numbers are just slightly above 40%. And this data also shows the difference between those who speak English very well and those who don't speak English, who are limited English proficient, showing the gap for those who are limited English proficient. The slide on the right shows a similar pattern for Hispanics as well. And then in Hawaii, this data shows for Native Hawaiians, while there has been improvement from 2000 to 2010 in almost all the categories, for Native Hawaiians, they still lag behind whites in terms of having a diabetes education in place. And then for asthma, another very common condition where we have clear clinical guidance on how to manage asthma, and as challenging as that may be, it's really one of those areas in which quality improvement can be demonstrated relatively quickly. And so here again from California, the California Health Interview Survey, while California as a whole is about at 70% for having a management plan for individuals with asthma, it's much lower again for Asians, particularly for Vietnamese and South Asians, and again a differential between those who speak English and those who don't speak English very well, who are limited English proficient. For congestive heart failure, this slide comes from the Agency for Healthcare Research and Quality, using their quality database, and it shows that for Samoans, the emissions for congestive heart failure are clearly way out of proportion for Samoans in this case and other Pacific Islanders compared to whites. Lower, obviously, is better because it means that the congestive heart failure is being managed in some way as opposed to being needing to go to the hospital. And then finally, a series of slides about end-of-life care. And so here are hospice patients. As our population in general grows older, these kinds of measures are going to be more and more important over time. This is a hospice patient who didn't receive the right treatment or response to them reporting anxiety or sadness. And here, for Asian Americans, nearly 1 out of 5 didn't essentially have any response to this report of anxiety or sadness, which is the highest for all the racial and ethnic groups. And then finally, for hospice patients who have clearly expressed what their end-of-life wishes might be, nearly 15% of Asian Americans and Pacific Islanders didn't have that wish respected or implemented by their hospice provider. And so again, here's a clear differential where folks at the end of life have expressed what they would wish, and the healthcare system has not responded to them. So I think we can look at other data points, but I'm going to stop there and really make the point that whether we're looking at state data from California and Hawaii or federal data from federal sources, that the story is the same, that there are significant disparities for Asian Americans, Native Hawaiians, and Pacific Islanders, as well as by English proficiency and sometimes by income when we have that data, and that there's a lot of room for improvement when it comes to these medically underserved populations on how we can improve the quality of healthcare for them. The other point that is made through this slide, through something called the Dartmouth Atlas of Healthcare, is that the darker shades, particularly in the South, show higher levels of discharges, which also then means higher level of admissions for what are called ambulatory sensitive conditions. So these are things like asthma, where if there is good management and treatment and control in the outpatient setting, then an individual with asthma doesn't need to come into the hospital for an asthma-related condition. And yet, in those states in which it's darker, in those regions within states in which it's darker, there are these wide variations where individuals, in fact, are being admitted to hospitals for these kinds of conditions. And so the question then is, why is this so, and why do those kinds of regional variations exist? And this was a well-written article in the New Yorker by Dr. Atul Gawande, which talked about both the mismatch in terms of the supply of healthcare providers, as well as really the organizational culture in those institutions that really encouraged these essentially unnecessary admissions that really didn't have any impact on the ultimate quality of care or the quality of health of the individuals who are then overutilizing these services. We see the same thing from the Institute of Medicine, their 2012 report, which is that up to 1/3 of our healthcare expenditures in the United States are these unnecessary expenditures. And so the question often comes, don't we have to spend more in terms of quality improvement to get the healthcare quality higher? And the answer is probably not, that we may have to simply redirect how we're spending those healthcare dollars, and that there's up to 1/3 that can be squeezed out of the system without any impact on health, because those expenditures are either unnecessary or otherwise wasteful. For Asian Americans, this was a study published in Health Affairs, which looked at whether or not Asian versus white Medicare beneficiaries, again, essentially controlling for their access to health care because they were in Medicare, they had a primary care provider, they had access to health care, but they still, in every metropolitan area, they still lag behind, Asian Americans lag behind in the level of colorectal cancer screening. So again, even when we control for whether or not someone should have health insurance and access problems, then we still don't see the efficiency in terms of the actual receipt of recommended screenings. So turning from the negative landscape of medical errors and not so great quality overall, both in the inpatient setting, hospital setting, as well as in the outpatient ambulatory setting in community health centers and physician practices, what do we do to try to make an impact, to make improvements on this level of quality? So now I'm going to turn to some first quality frameworks developed by the Institute of Medicine and other organizations, and then talk about how these quality frameworks have been incorporated through the Affordable Care Act into our ongoing efforts to reform healthcare in this country. So first we go back to the Institute of Medicine, and soon after they developed their initial recommendations, they talked about this very broad framework of improving quality that talked about patient safety to reduce those medical errors, to provide timely, effective, and efficient care, but also importantly for medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders, also talked about patient-centered care and talked about health equity, that the quality of care had to be equitable and address health disparities and reduce health disparities as an essential part of quality. So the Institute of Medicine recognized from the very beginning that quality was not a one-size-fits-all kind of proposition, but that we really needed to pay attention to these disparities from the very beginning. In this report, oftentimes folks know about those 6 elements of quality that the Institute of Medicine talked about, but they also talked about these 10 rules. And these rules you're going to see very familiar as themes coming up through the rest of this webinar. And then as we move into the other webinars focused on health information technology and medical homes and accountable care organizations, you're going to see these themes coming up to try to implement these rules that the Institute of Medicine articulated way back in 2001. So the first rule is that there's this ongoing continuous relationship with the healthcare provider, that the care is customized or patient-centered, that the shift of control over healthcare decision-making and knowledge moves from the provider to the patient and is shared with the patient, that decision-making by healthcare providers is evidence-based and follows those clinical treatment guidelines that we talked about, that safety is a priority for the entire system throughout the system, and that there's transparency about these outcomes, that the needs of patients are anticipated, waste is continuously decreased, and cooperation and collaboration, especially in transitions of care, is a priority rather than pointing fingers and saying, I did my job and it's not my responsibility to follow my patient across the continuum of care. And so these are rules that, again, were articulated by the Institute of Medicine that you will see incorporated into some of the quality improvement work that is now ongoing. The Institute of Medicine followed a year later with this report about specifically reducing health disparities and made specific recommendations around data collection, around communication, and building trust, especially with disparities populations, and broader strategies to engage communities on an ongoing basis to continue to build and strengthen that trust with communities that often were not served well by the healthcare system. And as we see from the data, this is a continuing issue to build that trust, to really reassure communities that have experienced these disparities that the healthcare system will actually help them get better and improve their outcomes. These elements of quality improvement and disparities reduction were further integrated through a report from the Institute of Medicine in 2010, and it really talked about the final point, which is that we really wouldn't make progress on quality improvement and disparities reduction unless we really establish very, very specific goals and objectives. That it was fine to talk about these things as concepts and to report on our progress, but the key point of this particular report in 2010 was that we really needed to establish clear goals and objectives, just as individually in our programs we want to identify what it is that we want to accomplish within our own organization and for our own clients and patients and communities, that at a national level we also needed to establish these goals. And so this is the framework that talked about, again, looking at these elements that the Institute of Medicine had set out across the entire continuum of care. So another way to think about this in healthcare policy is that we have to address issues of access to make sure that, again, when we looked at data and we can look at other data for people who are uninsured and don't have access to healthcare, their quality outcomes, not surprisingly, are always worse. And so thinking about increasing access to insurance, but also paying attention to both the elements of quality and reducing costs through especially unnecessary utilization and waste. Another very important healthcare quality improvement organization called the Institute of Healthcare Improvement changed this access, quality, and cost triangle to what it called the triple aim, and this is now going to be a very important framework for us moving forward. So rather than access, what the triple aim says is even if you're uninsured, you're going to access healthcare in some way, perhaps in the emergency room, but you will get healthcare sooner or later. And so really what we're trying to do is not just get everybody insured, but really ensure that people have a good experience of care, a primary care provider who has that continuous relationship with you, and the appropriate utilization of hospitals and emergency rooms. So again, back to the regional data from the Dartmouth Atlas, we don't want people showing up with preventable conditions in the emergency room or in the hospital. We want to take care of them in the ambulatory setting. And then in terms of quality, rather than just focus on doing better on this measure or that quality measure, we really want ultimately to improve the health of the people of the United States. And so it boldly set forward, we don't want to just do quality measure improvement, we actually want to improve population health. And that's a much bigger goal and a much more difficult goal and a challenging goal to try to reach. And then finally, in terms of cost, we don't want to just, again, point fingers and say, let's shift the cost from this provider or this payer to that provider or that payer. We ultimately want to reduce costs. If 1/3 of our U.S. healthcare expenditures are unnecessary, that's good for us to save that money overall. And so really the goal is not just to shift costs around, but to reduce the overall cost of healthcare in the United States. And this is the article that the triple aim was really first articulated in Health Affairs. The first name on that, the author of that article is Don Berwick, who eventually became the administrator for the Centers for Medicare and Medicaid Services in 2010, and tasked with implementing the healthcare reform law. And so you're going to see his fingerprints and signature on moving the triple aim goals and framework into healthcare reform. What the Institute of Healthcare Improvement then did was demonstrate that it could not only just come up with this really great framework of the triple aim, but could actually make change, could make quality better. And so in 2004, it started what it called the 100,000 Lives campaign, and got 2,000 hospitals across the country to, again, focus on common goals. These are primarily patient safety goals, and save 100,000 lives over that 3-year time period, but also improve patient safety and healthcare quality. So as a result of that 3-year campaign, they actually went over their goal, and they saved what they estimated was 122,000 lives. They ultimately got over 3,000 hospitals engaged. And these are the kinds of interventions that they implemented: rapid response teams, medication reconciliation, making sure that they were paying attention to patient safety issues for ventilators and central venous line that were largely responsible for a lot of those medical errors and the harm that patients were experiencing. Not satisfied with that goal, IHI then implemented another 3-year campaign, which they called the 5 Million Lives campaign in 2008 to 2010, where they were seeking to enroll over 4,000 hospitals and avoid over 5 million incidents of harm. And they met those goals as well. And that led us up to healthcare reform, which we'll come back to in a moment. The last model I wanted to highlight as a conceptual model really focuses on the outpatient side, and this was developed by Dr. Ed Wagner from Seattle and his colleagues, and it's called the chronic care model. And this does talk about how you manage a chronic care condition like diabetes or asthma, but it also talks, the important thing about this is it really links on the left-hand side what healthcare systems can do in terms of physician support and how you have better interactions with the healthcare team to really making sure that there's connections between the healthcare provider with the community, with resources, with self-management support, with peer support, with other support in the community. So this is actually a very holistic model that talks about not only what the healthcare providers and systems can do, but how those healthcare providers and systems can partner with community-based organizations, community resources, home and family resources that really are going to make that impact on population health that is going to make a difference. And so now we turn to 2010 and the enactment of the Patient Protection and Affordable Care Act. While we have focused in the last couple of years on the health insurance provisions and the state and federal marketplace for insurance, and seeing that up to 11 million Americans have received health insurance either through the marketplaces or through the expansion of Medicaid in their particular states. The healthcare reform law also actually had a lot in that law about healthcare quality and healthcare cost. And so a year later, after the law was enacted, the Department of Health and Human Services adopted for the first time a national strategy for quality improvement in healthcare that had 3 principal goals. The first was better care for patients and individuals, which mirrors the access or better patient experience of care; healthy people and healthy communities, which mirrors the quality or population health aim of the triple aim; and finally, affordable care or reduced costs, which is the third element of the triple aim. And so, especially because Dr. Berwick was now at the Centers for Medicare and Medicaid Services, the triple aim now has become the official framework for national healthcare quality improvement. So what the triple aim then did was say in this national healthcare quality strategy, we needed to emphasize patient safety, we needed to engage patients, their families, as partners in care, we needed better communication with healthcare providers, patients, and families. We needed better communication among healthcare providers in the coordination of care. We needed to promote evidence-based practices. We needed to work with communities similar to the chronic care model to form partnerships with community resources to advance and make progress on population health. And we needed to make healthcare quality an issue of affordability by developing models that would be more efficient and cost effective. So one of the first things then, very similar to the Institute for Healthcare Quality Improvement that Dr. Berwick started, was he started the Centers for Medicare and Medicaid Services Partnership for Patients. in 2011, which was now not a private initiative, but a federal government initiative to focus on quality, with the aim of engaging hospitals and achieving specific benchmarks and goals for patient safety. So today, that partnership continues with over 3,700 hospitals participating and achieving very, very specific patient safety and quality improvements. The other thing that has been a huge area of focus is a readmissions reduction program, also spearheaded by the federal government. And if you look all the way on the right-hand column, this is the level of readmissions. Again, in Medicare, remember I said that it was about 1 in 5 of Medicare patients went back to the hospital after being discharged for a preventable or avoidable reason. And these are now the conditions for heart failure and for pneumonia. And so these rates are floating down. We are making progress. So initially, it was at 24% for the heart rate, and it's now moving down. It was nearly 18%, and we're now moving, or is at 20%, and we're now moving to 18% for pneumonia. So these rates are going down, and we're going to be continuing to add conditions like hip and other joint replacements to try to focus on bringing those levels of readmissions down. We still have a ways to go. We're doing better, but we still have a ways to go. And we're changing, again, the organizational culture in hospitals around these readmissions. We're also focused on other broader transitions of care when people are discharged. And so there are these programs all across the country to do better discharge planning and to reduce those readmissions and improve those transitions of care for individuals being discharged from hospitals. And then what I really love about the Affordable Care Act and healthcare reform is that the federal government also recognized that it didn't have all the answers. And so, what we now have 2 rounds of these healthcare innovation challenges, which are really looking to communities and providers to come up with their ideas. And so we now have nearly 150 of these innovation awards out in the field, where they're testing different ideas for all kinds of populations, including Asian American, Native Hawaiian, and Pacific Islander populations, on how we can improve quality and reduce costs. We're also, on the cost side, really experimenting with this notion of bundled payments, which is saying how much does something like a hip replacement cost, and how can we pay for that when someone needs that hip replacement from the very beginning all the way through rehabilitation and home health, and not have individual pieces of that entire course of treatment being paid, but really hold all those providers across that continuum of care accountable for holding those costs down, and various ways then to incentivize how that might be done. States are also involved in this, and so not only at the community level, but at the state level, states are putting forward ideas to the Centers for Medicare and Medicaid Services. Many of them are incorporating these ideas in their Medicaid programs, and so many of them are also doing multi-payer initiatives of trying to bring together the best knowledge that they have about quality improvement in Medicare and Medicaid and bringing them together. Some of them are also working with commercial health plans in their states, and so there's all kinds of innovative activity on quality improvement and cost reduction happening in states. And then finally, the latest development from CMS is really exciting to say that we also need to support those physician practices, including community health centers and their physicians, who maybe haven't had as much support for testing these new kinds of quality improvement and payment models. And so there's going to be new awards awarded just this month for networks of physicians and clinicians to learn about quality improvement practices and implement them in their particular networks. And so they're going to academic institutions, healthcare controlled networks, We expect some will be awarded. Some regional extension centers that have been working on health information technology implementation are likely to be awarded. So a whole number of different kinds of support organizations for clinicians to work on quality improvement in their particular practices. So finally, I want to end on a couple of notes about summarizing what we learned from all these. And again, we'll talk about these more in detail in the subsequent webinars when we look at some of the specific initiatives like medical homes that are trying to move healthcare quality improvement and cost reduction. We generally know that measurement is really important and data is really important, and particularly for medically underserved Asian Americans, Native Hawaiians, Pacific Islanders, limited English proficient, and other underserved populations. Collecting demographic data and stratifying that data by those demographics is also really important. We also know that it's really important to set baselines and specific goals. So if you're at 40%, it's unrealistic to expect that you're going to move to 90% tomorrow or next year, but it might be realistic for you to move from 40% to 50%. So what are realistic improvement goals to set for yourself using the best performance as really the highest benchmark to be trying to achieve. We also know in quality improvement that it's a trial and error, that while there are best practices, there is no one-size-fits-all approach, and that your particular community health center, your particular practice is going to be very different. Your patients are going to be very different. Your staff is going to be very different. And so there's a lot of wisdom that says that you shouldn't plan for just a single kind of improvement approach, but that you should constantly be testing and adapting and adjusting, repeating improvements as you go along, seeing what works for you and for your patients and your clients and your community, and really trying to sustain and scale up those particular measures and interventions for quality improvement. And so many use this plan, do, study, act cycle, where you are looking at what change you might want to make. You actually test that out in what are called small tests of change to actually do them. You summarize and look at whether or not you accomplished the change that you were seeking, and then you act further to implement that on a scaled up way. And you keep repeating that cycle over and over again in a quality improvement continuous cycle, rather than, again, just deciding on one single intervention or one single activity to try to gain those quality improvements. There's all kinds of complications. That PDSA cycle is displayed here in successive circles and stages. This is a framework that the Institute for Healthcare Quality Improvement uses called the Breakthrough Series, where they're combining these small PDSA cycles over time and then constantly measuring them, reporting, and improving on them as you go across the cycle. There are other models in industrial production. Toyota, Motorola use something called the Six Sigma quality improvement. There's something called the lean process, in which there's quality improvement in the industrial side that are now being adapted and widely adopted in healthcare, especially in hospitals, as a way, again, similar framework where you're planning something, you're looking at your data, you're seeing whether the data shows improvement, and then you're scaling up that improvement as your data goes along, but then you're constantly going through those cycles of change, study, and improvement as you proceed. And then we'll see these again, these themes of these kinds of constant, continuous quality improvement processes come up when we talk about the specific initiatives being implemented. So finally, I want to end with the implications for community health centers that are serving Asian Americans, Native Hawaiians, and Pacific Islanders. Unfortunately, we don't have a lot to report here. We do have some data that community health centers in general have successfully implemented quality improvement, have shown particularly on diabetes, significant improvements in outcomes. And we learn from those quality improvement projects, which will be referenced in the reference and resource list that will be available after the webinar, the specific citations for these particular studies, that's similar to what I just explained in terms of good quality improvement processes, focusing on the data, focusing on engaging staff and tracking those results over time, and really using staff and patients and collaborations and peers seem to be the common themes of what works well in community health centers. And I think the takeaway from this is because the staff of community health centers, particularly those serving Asian Americans, Native Hawaiians, and Pacific Islanders, are often reflective of the Asian American, Native Hawaiian, and Pacific Islander populations that they're serving. These are really great partners to be engaged in. So it's not just the physician or the nurse practitioner or the physician assistant, but it's the medical assistants, it's the receptionist, it's the peer counselors, it's the community health workers, it's the enabling services staff, it's the interpreters, to really be engaged in teams on quality improvement that would really bring in all the personnel and all the human resources and assets that that community health center has. We know here at AAPCHO, AAPCHO has focused on highlighting the importance of enabling services at community health centers, and that's really a very, very strong foundation. And as AAPCHO continues to collect data from its member community health services on enabling services and really demonstrating through data that that's one way, by providing those enabling services, that we can show those kinds of quality improvement. But the caution here is that it's just as the Institute of Medicine way back early in its frameworks talked about the need to pay particular attention to culture, to language, to disparities, we need to continue to pay attention to that. And let me conclude with these series of articles that talk about how important it is as we implement healthcare reform in particular, and the healthcare quality improvements and cost reduction initiatives in healthcare reform, that we also pay attention to health equity and health disparities, because if we don't, there is this danger that we actually exacerbate or make those disparities worse rather than making them better. And these are two articles that talk about that. So just as a reminder, we're going to take a deeper dive into some of these issues and talk about how health information technology and electronic health records can support this kind of quality improvement work, how patient-centered medical homes can also support this work, and then in terms of accountable care and shared savings models, how payment reform is also supporting this kind of quality improvement work. And then, as June mentioned at the beginning, conclude the webinar series with a focus specifically on the culturally and linguistically appropriate services integration in all these efforts, as we particularly highlight what that means for medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders. So let me conclude there and turn to questions.
Thanks, Ignatius. That was great. I think that was a great overview of quality improvement and provided a comprehensive framework of why all of us are looking at quality improvement measures right now. What we want to do now is to answer any questions our participants might have. So for those of you who are on the line and logged into GoToWebinar, if you could please submit any questions you have using the question box in your control panel. We will be taking those, and while we wait for any questions that might come through, I have one for you, Ignatius. A lot of the current and what's been done up until now around quality improvement has focused primarily on the hospital setting, I think. And so what do you think are some strategies health centers can use, because I know it's a really frustrating barrier that they face, to become more recognized as a part of this discussion or any initiatives?
That's a great question, and again, because community health centers are not hospitals and don't provide those kinds of inpatient services, although some community health centers are now beginning to do more urgent care and after-hours kinds of care from the traditional 9-to-5 schedule. I think the most important thing that community health centers can do is that healthcare is very, very local. So there are only a finite number of hospitals in your local service area that your patients are going to be needing to go to. If they need hospitalization, there's only a finite number of emergency rooms that your patients are going to go to if they need emergency room services. So really establishing those linkages, those connections. We'll talk later in webinars about how health information technology can support those kinds of linkages in a more formal way, but really establishing those kinds of relationships. Again, when I had been doing some work on reducing readmissions and improving transitions of care, I was really surprised for the hospitals that I was working with that they actually didn't know and have relationships with their primary care providers, their community health centers. They were discharging their patients back to these community health centers and primary care providers, but they didn't have any formal relationships with them. And so again, just getting to know who those folks are, getting to know how many of your patients go to those hospitals and emergency rooms, and then even asking your patients what their experience of care in those hospitals and emergency rooms are, gets you into that conversation to begin to really build out that continuum of care that will better serve your patients and communities.
Another question we have is around quality improvement plans. All health centers are required to have one, and I know that one of the most common technical assistance requests that AAPCHO receives is for samples or resources that folks can reference while building out and reiterating their quality improvement plans. Do you have any specific resources and or advice for folks who are currently developing or evolving their quality improvement plans?
So another great question, and again, I think to reflect back on some of the common frameworks, I think the first way I would answer that question is to look at your own data, the data that you are required to report in UDS, and there are some specific quality measures related to diabetes, to prenatal care, to other kinds of quality that all community health centers are required to document in UDS. So look at your own data and see how you're doing compared to the national measures and national levels of quality for those particular measures. If you're doing fine and great, move on to something else. If you're not doing as well, then you might want to focus on making improvements, because again, that's going to be the first thing that the Bureau is going to be looking at. Are those data that you're reporting already? But again, if you're doing well, then think of something else, whether it's asthma, whether it's starting to deal with an older population that you're beginning to see, whether it's working with a teen population and adolescent population and their health measures, whether it's integrating something like some of the oral health measures and how well you're integrating your oral health services with your medical services, or your behavioral health services with your medical services. So there's lots of different areas that you could look to, and I would say it really should be driven by your own data on what you develop your quality improvement plan on, and then depending on what those benchmarks are, again, being realistic about how much change you would expect to see over 3 months, 6 months, 1 year, and then implementing what you might consider the small tests of change, these plan, do, study, act cycles. So the common way to do a quality improvement plan is to get all the people that would be involved. And here I would encourage you not just to have it physician-driven, but bring in the medical assistants, bring in the front receptionist staff, bring in your community health workers, bring in everybody else who might help on that particular issue, and get their ideas of how they could design a quality improvement intervention, and then test that out for a week, for even a couple of days, and see whether or not there are improvements, and then eventually scale that up across your community health center for all those patients who have that particular condition. One of the challenges to doing quality improvement is oftentimes as many patients as you see, you may not have enough patients with that particular condition because the quality improvement is pretty condition or diagnosis or disease specific. So again, that's why I say you should start with your own data to see what you need improvement on and then move from there.
Great. Well, I think we're just about out of time. I do want to remind participants that slides and the resource list that Ignatius mentioned are going to be emailed out to all registered participants. And as Ignatius also mentioned, we will be conducting our next webinar next Wednesday at 12 p.m. Pacific time around health information technology and its implications for community health centers. So please be sure to register. If you haven't already, you can find registration information on our website, www.apcho.org, and or through the email that you were already sent or the reminder email that we're going to be sending out. Thank you very much, and we look forward to speaking with you next week.